mess of these goggles at first and roots at the end, our output gets messed up by the same amount. So the brain is doing all of our processing for us, as simple as input and output that we showed you just now with our demonstration, but so much more as well. So round of applause for Ruth and Tate for coming up and humoring me. So yeah, the brain is responsible for everything that you do. All of your thoughts, feelings, actions, behaviors, that's all going on in your brain. And so when anything goes wrong with your brain, any of those functions can get disrupted. And so I have a very nice picture here of a brain. This is an MRI of a brain. So it's acquired using magnetic resonance imaging. And I'm just going to give you a little bit of a rundown of some of the regions and structures of the brain, so that we can kind of all have the same language as we go through. See where my mouse is here. Great. So we've got 3 slices kind of through the brain, but MRI is this really exciting medical imaging technique because it's totally non-invasive. So when I say slice, kind of sounds like an invasive technique, but that's just how we visualize it. So we've got the image, sorry, was there we go. We've got the image here where it's kind of looking as if, well, it's as if you've cut my face off and you're looking straight at what's left. So you can kind of see the spine going down, but the brain up here. And you can see the darker tissue here is gray matter. And so you might refer to your brain as your gray matter, like as a joke, but gray matter is a real tissue in the brain, but it's not the only tissue in the brain. It's also white matter, which is underneath. And then the brain's divided up into different lobes. So you can see big structures here, like this is the temporal lobe, which is really important for memory and language. We might talk about that a little bit more later on. You can see the ventricles. So there's your brain kind of floats and is bathed in this fluid. It's called cerebral spinal fluid, or CSF. And all the dark areas on this picture are that fluid. And it's really important for providing nutrients to your brain and also just protecting your brain, right? From, for example, thudding onto your skull if you were to bump your head. And I should have mentioned before, at any point, if anyone has a question, happy to take those as we go through, have a little bit more of a conversation. And then this image here, you can see now we've got some gray matter. And this is my favorite brain region, corpus callosum. Maybe now that I've said it, it'll be your favorite brain regions too. It's important to have a favorite brain region when you study the brain. So this is a big tract of white matter that connects the 2 hemispheres. And then in this picture too, you can kind of see the person's nose. So it's kind of like halfway through the cerebellum, or the little brain, and then the spine going all the way down. And then this is another view as well. Now it's kind of as if you're at the top looking down, and you can see those ventricles again, and the gray matter on the outside and the white matter. So we're able to take these really, really detailed pictures of the brain with MRI and look at all these beautiful structures in only about 4 or 5 minutes now. We can acquire these really detailed, beautiful structural pictures of the brain. And so that's really exciting. And the other kind of bit of neuroanatomy, I want to make sure we all have some language to share today, are neurons, right? So neurons are brain cells. They're the building blocks of the brain, the cells of the brain. And so here's just a kind of a schematic of the neuron. So the neuron accepts its input from this end. They're called the dendrites. And then it does some processing in the cell body here. And then it sends its output down its axon. And then neurons kind of build these neural networks to form the brain, to do all sorts of complex processing. Sometimes we use this analogy, the brain is like a computer, but the brain is so much more than a computer. And sometimes I challenge my students to come up with a better analogy. Is there some better way we can explain the brain? It's like a computer. It's got input and output, and it does processing, but it does so much more, and it has so much more complexity than computers that we have now. So by all of these different combinations of neurons building networks together, we can produce really, really complex processing that is responsible for all of our thoughts, feelings, and actions. Any questions about, yeah, thank you. What's up?
How many connections?
Yeah, how many connections can each individual neuron have? It's totally dependent on where the neuron is situated and the experiences that it's had as it's developed. And we can even have changes like you're kind of mentioning, which we call neuroplasticity, as the changes between the neurons, or as the connections between the neurons change to, strengthen a new skill, for example. But we don't have I can't give you a hard limit on how many connections. I'll just say very few to very many. It's not a super specific answer. And again, that's providing part of that complexity, is that we can have a big range in the differences. And so I'm going to be talking today a lot about brain aging and brain health in aging. It's a research interest of mine. And here's a cartoon kind of at the top about what happens to the brain as we age. It's a little bit exaggerated, so you can see all of the parts. So we've got a picture here that's just like this one. But now it's just a cartoon, but you can still see the dark gray matter on the outside and the lighter white matter on the inside. So this is a relatively younger brain half compared to a relatively older brain half. So you can see the area where the cerebral spinal fluid is that bathes the brain, they grow, and the other areas of the brain tend to shrink, or we might use the word atrophy. So we can see thinning of that gray matter on the outside. It's also called the cortex. Overall volume loss. And then the sulcal widening. So the bumps of your brain, and I've got some models here too that we can show, or you can come up and look at after. So the ridges, the high parts are called a gyrus or gyri, if there's more than one. And then the sulci or sulcus are the grooves. And so sulcal widening is another observation that we make as brains age. And this is just a normal part of development and aging. We see these changes. There's another diagram here where you can see the widening kind of in blue. So the blue area is a bit bigger. The gray area, that cortex on the outside, is thinner. And the red ventricles here is wider as well. So like I said, this is sort of a normal part of development and aging. But what isn't normal, what we want to avoid, is dementia. And there's a lot of misconceptions about what dementia is that make it hard for us to make good decisions for our own health and the health of our community. So maybe I'll put it out to you. When I say dementia, what do you think of when I say dementia? Forgetfulness, Derek? Close relationship with Alzheimer's, yes. Emma? A loss of neural connections, absolutely. Anyone else? Yeah. Care partner burden, family burden, absolutely. Okay. And so dementia is not a part of healthy aging. And that's one common misconception that people sometimes misbelieve or believe that, oh, everyone gets dementia as they age. That's not true. There's always some loss of certain functions. So your memory isn't as sharp when you're 80 as when you're 20. That's true. But it's not the same as dementia, where your memory has a much worse decline. So there's a normal aspect of aging where we do lose some memory, but not to the level of dementia. So dementia, we can define that a little bit better too. So when we say dementia, we're thinking about problems with thinking and memory that are impacting our daily function, impacting our daily life. Not a part of healthy aging. Dementia is also not a disease. So it has this close relationship with Alzheimer's, like Derek mentioned, but dementia itself isn't a disease. Dementia is a symptom. Just like a cough isn't a disease, a cough is a symptom. It might be the cold, it might be COVID, it might be the flu, but a cough isn't the disease. So dementia is a symptom. One of the causes of dementia is Alzheimer's disease, but there's other causes too, and we're going to talk about some of those today, which are just not as well known. That oftentimes when we think dementia, we automatically think Alzheimer's disease, but there are other causes of dementia. And the kind of exciting part about this is that one of the other causes, there's a lot of potential for it to be prevented and maybe even treated. So yeah, dementia is a symptom. And so some of the conditions or diseases that can cause dementia I have on the slide here with some different images of brains of patients who are experiencing these causes of dementia. So we have a control brain. So this would be someone approximately the same age as the other people whose brains we're fortunate to be able to share today. And so you can see different characteristics, and we can focus on Alzheimer's disease here, where you see a very dramatic widening of these ventricles. So this black area here that holds that fluid is much larger. And can you see these kind of holes here and here? They're sort of, it's a little bit symmetrical. You've got a hole on either side. That's an area called the medial temporal lobe, which is where your hippocampus is. The hippocampus is very important for memory. You might have seen a movie about, it was inspired by a patient who had surgery to remove their hippocampi on both sides. So has anyone seen Memento? That movie with Guy Pearce? Yeah. So it's about a person who's lost the ability to form new memories. And it's also like a action mystery kind of movie, but the neuroscience part is that he's lost the ability to form new memories, and it's actually based on a real patient called patient HM. And we heard about patient HM, some nodding. So patient HM was a patient who had very, very severe epilepsy. They had very severe seizures very frequently. And they took the patient in and mapped where the seizures were coming from. And they said, oh, it's the hippocampus on both sides. So basically this area that's atrophied due to Alzheimer's in this patient, they surgically removed in our patient that I'm talking about, patient HM. And it was effective in reducing their seizure frequency and severity, but HM lost the ability to form new memories. So he moved shortly after he had the surgery and never learned where the rooms in his house were, new house were, the places where they kept things. He was studied for decades by researchers and clinicians. He never remembered their names, never learned who they were. So the hippocampus is extremely important in the formation of new memories, and you can see how degenerated it is, how shrunk. It's basically a hole of fluid and not a structure anymore in patients with severe Alzheimer's disease. So I think just by being here, you're interested in brain health and how we can improve brain health. And so this is a little bit, information that you might already know or already be worried about. But one of my main motivations for studying dementia and brain aging is the expected rise of dementia cases in Canada. So we're looking in the next 25 years or so of an expected increase rate of 187% of dementia cases in Canada. And I'm sure you already all know how strained our health and social systems already are, and what a huge burden this will place and continue to place on an already overburdened system. And what's worse is that the predicted increase is even higher among Indigenous populations. So the 187% figure is for the general Canadian population, But among Indigenous individuals, the rate of dementia is expected to rise by 273% in the same time period. So what can we do about this? What changes can we make? What actions can we take to try to not have this happen and to make this prediction false? Because if we don't do anything, this is the path that we're on. So one of the most promising ways to consider reducing the potential future burden of dementia is thinking about how our heart health impacts our brain health. And vascular factors like your heart and your blood circulation are a leading cause of dementia. Almost as big or pretty close, depending on the estimates, as Alzheimer's disease. So vascular factors are as important in the causes of dementia as Alzheimer's disease. And many people with Alzheimer's disease also have some disease in their brain related to vascular factors as well. So it's often not like a really clean diagnosis, oh, it's just one or the other. We often have these mixed dementias. And so improving heart health is one of the most promising ways to prevent dementia. And this is true both like for me as an individual, for all of you as individuals, but it's also true but more broadly for our community and for our population. So we're going to kind of think about some ways and talk about some ways to try to help with both our individual health and our community's brain health. But first, a little bit more of the science. Why are vascular factors such a driving force behind dementia cases? I think it's fair to say that it relates to this idea of neurovascular coupling. So the brain makes up only about 3% of your body's mass. It's pretty small as far as organs go, but it accounts for 20% of your body's energy demands. And the brain is sort of funny in that it doesn't store its own energy. So even though it needs all this energy, it doesn't keep stores of energy like the way your muscles and your liver do. And so to meet those really high metabolic demands, those really high energy demands, the brain has this really tight vascular control associated with brain activity. So that's called neurovascular coupling. When one part of your brain is active, blood flow increases to that area to feed those hungry neurons so that we can provide the glucose and the oxygen that those neurons need to do the work that they're doing and also clear wastes. So neurovascular coupling is a really key concept in understanding why vascular health is so important to brain health. Because what happens, what might you think happens if you have an area of neurons that are active, they're busy, they're working hard, but the blood flow to that area isn't as good, or it isn't as good at being regulated? What happens to those neurons? You might lose them after a long enough a period of time if there's no blood flow at all, which happens in the case, for example, in a stroke. So a stroke would be if you've got a blockage of blood flow to a certain part of the brain, or sometimes a bleed, depending on the type of stroke. So those neurons could die and you could lose them altogether. They might just not function as efficiently as they could if they're not getting their energy demands met. So we need to feed our hungry brain. And so just as a little visual here, pretty sure that I'm not sure, I actually don't know. But so when your neurons are at rest, your blood vessels might look something like this. And then when your neurons are activated, just in the region that they're activated in, you can see this what we call vasodilation. So your blood vessels get wider and they allow more blood to flow through to that area. And we actually don't know exactly how this works. There's a lot of really complex chemical signaling that goes on that we've done a lot of work to map out, but we don't know exactly how it works, and we don't always know the mechanism when it gets disrupted. But we do know that it happens. And so one of the reasons that I find neurovascular coupling so interesting is that it's actually what we measure for a lot of functional brain imaging techniques. So you might know, and I'll show you some pictures in a minute, we can measure your brain's activity. We can map brain activity non-invasively. But a lot of the techniques that we do that actually aren't mapping brain activity directly at all. They're sensitive to those blood flow changes that are so tightly linked to brain activity. And so some examples here are functional magnetic resonance imaging. So the picture I showed you before was of a MRI image, a structural picture, but you can use the same machine, and I've got a picture of it here, to take images of brain function, to map where in the brain different functions are taking place. And so this is actually the scanner that I used in Calgary. One of my colleagues is testing something out for me here. Nice guy. And so if you've ever had an MRI before, you know that you lie in a tube, like a very narrow tube, and it can be quite loud. And I know that for patients who maybe haven't had an MRI before, it might not be the most pleasant experience. When you've done MRI research for 20 years, you sometimes like fight over being the participant because you sort of get to lay down at work, get a little bit of a rest, and it kind of becomes a very relaxing place to do some thinking, or depending on the scan, maybe have a nap, not for functional MRI, please. When we want to look at your brain function, don't fall asleep, but structure, no big deal. And so we get pictures that look like this. So here we have a nice structural image with the white matter and the gray matter, like we showed before, but overlaid on it, we have these kind of beautiful, really compelling maps of where was the brain active during a certain task. And this is actually an old image from my PhD work where we were showing for the first time that you could see brain activation in white matter. So it was thought before that you couldn't use this technique to detect activation in white matter. You could only use it in gray matter, but you can see this little cluster here changed how we look at these measurements. So there's something else I want to say about that. Any questions about fMRI? So we're able to non-invasively measure brain function, but remember, we're actually measuring blood flow changes, not the brain activity directly. And what we're actually doing here, I can share, is we're taking advantage of the magnetic properties of the blood. So the M in MRI stands for magnetic. Probably know there's iron in your blood. That's basically what we're mapping. And it's got the iron in your blood has different magnetic properties depending on whether it's bound to oxygen. So if it's fresh blood or if it's not bound to oxygen, if it's going back to the lungs. So that's how we map brain function with fMRI. Another important thing to know about MRI, just in case anyone ever needs one, or maybe you've already gone in and this didn't come up, but it could come up later. This is I blame TV for this. The MRI is always on. It's always on. We can't turn the magnet off. The way that we get these really strong magnetic fields to do MRI is actually these super cool superconductors. So it's like a giant electromagnet bathed in liquid helium at very, very cold temperatures to get enough electricity flowing to these really strong magnets. So if you want to turn the magnet off, you have to boil off like tens of thousands of dollars of liquid helium. So the magnet's always on. But sometimes on TV, the magnet is not always on, and people go into the MRI room and maybe have magnetic things on them that don't immediately fly off of them and create dangerous projectiles. So it's always really important if you ever get an MRI to make sure you're not bringing in anything magnetic. And they'll tell you that too, but just where this TV has confused us, I like to bring it up when I can. Yeah. So that's an interesting question. Could a magnet impact the blood in a negative way? So we're talking about different types of magnetism. So when we think about the type of magnetism that's pulling my, I don't know, my cell phone out of my hand when I accidentally bring it into the MRI room, that's ferromagnetism. The type of magnetism that the iron in your blood has, depending on whether it's oxygenated or not, is either diamagnetic or paramagnetic. And so while it has magnetic properties that we can measure, we're not applying forces in the same way that would. When you said it, I imagined something very dramatic, but we don't have to worry about that because it's a different type of magnetism. That's not the type of magnet that you're using with your fridge. Interesting question. Yeah. So that's fMRI, but another technique that we use to measure brain function that relies on neurovascular coupling or blood flow is FNIRS. And so this is a mouthful of an acronym, but it stands for Functional Near Infrared Spectroscopy, which is a mouthful of a phrase as well. So I don't know which is better and which is worse. But what this device does, so you can see you no longer have to be in a tiny narrow tube. You can wear this cap. And each of these cylinders attached to the cap contains what's called an optode or an optical sensor. So, your pulse oximeter, you put on your finger, you can see the little red light and it says how oxygenated your blood is. Very similar technology, except instead of measuring the blood in your finger, we're measuring the oxygenation of the blood in your brain, on the outer layer of your brain. So now, instead of taking advantages of the differences in the magnetic properties of blood, we're taking advantage in the different optical properties of blood. So oxygenated blood is more red, and deoxygenated blood without oxygen or less oxygen, is more blue. And so we can use light to map blood changes that are associated with brain function as well. Very similar to fMRI, but we're only sensitive to the outside of the brain with this approach. The light that we send in to detect doesn't have a very big path. It can't get really deep. So the pictures that we produce are a little bit less compelling, I would say. We don't get information about the deep structures of the brain. We can learn about kind of the overall trends in brain activation at the surface. Can still be very useful, but you can't map with that same spatial precision. But this device is an order of magnitude less expensive. Important. We have one here in my lab, and we'll be starting up research projects soon where you can come in and have your brain scanned with the FNIRS, and hopefully we'll be able to translate that into a way of testing brain health, cerebrovascular health in the future. So that's something that we're working on here. And they're a lot more comfortable and a lot safer. So imagine somebody with an implant like a pacemaker. It's not safe for them to have an MRI, but it's perfectly safe for us to measure their brain function with a device like this. So different pros and cons of the different strategies, but both are fundamentally measuring the blood flow changes associated with brain activity or neural activity. Any questions about techniques, Emma? It's an interesting question. So is there a way we could improve the technology to penetrate so that we could image function in deeper brain regions? Fundamentally, the light has to pass through all these other layers, and there's just not much left by the time it gets to the brain in the first place. So I'm not clever enough to come up with a way to do that, but it would be a question for people who develop optodes and physics, engineering, biomedical engineering people. I'd love to collaborate with someone working on a question like that, but yeah, I can't think of a way that we could do that. I think of it as a fundamental limitation, but maybe I'm thinking too small. Thanks for that. Derek?
So we talked about how both fMRI and FNIRS, they effectively measure blood flow. So I'm curious, how does, say, for example, body temperature and or blood pressure, how do these factors impact, say, accuracy or sensitivity of the measures?
Right. So Derek's mentioning a few possible confounds like body temperature or blood pressure. And there's other techniques. This is sort of a funny maybe this is true everywhere, but I really noticed it working in the university. We kind of get into silos of our little work that we do. So there's actually a third technique that measures brain activity based on blood flow that I didn't mention because I don't do it, which is called a transcranial Doppler. And it's based on ultrasound, it's based on sound. So we can use magnets, light, and sound to measure blood flow associated with brain activity. But I bring that up because the transcranial Doppler folks always measure blood pressure. We never do. Probably we should. But there are other compounds that we worry about, things like caffeine intake. So caffeine intake, you might know that caffeine is a treatment for migraine, and it can change the blood vessels in your brain temporarily. And so if you've had like a lot of coffee, or you skipped coffee and you normally have a lot of coffee, that can have effects on your brain scans that if we brought you in a week later and you had different caffeine, we might see a different result that wouldn't be related to your brain activity at all. But I also worry about things like normal changes in blood flow associated with age. If we want to look at brain activity with these techniques, now we're mixing up the two things, right? So is it that there's been a blood flow change with age, or is it that there's been a brain activity or a brain organization change with age? We don't know because we've mixed these things up. So some of the work that I did in Calgary was to use more what we called physiologically specific, but we use more complex techniques to try to start to tease that apart a little bit. But there's a lot of like physiological variables like blood pressure and temperature that could absolutely have an effect that we don't always do a great job of controlling for. I see some questions online too. How much of a time delay is there between the actual neural activity occurring and the change in blood flow? Great question, Kate. So the blood flow responses that we measure are kind of sluggish. And brain activity, your neurons work really, really fast, like milliseconds. They're doing different things and sending different signals. Blood flow takes 5 to 8 seconds to peak after a kind of a burst of activity. So it's very sluggish. So sometimes we combine it with other techniques that measure the neural activity faster. We can kind of look at sort of a multi-dimensional approach. Awesome. Okay, so maybe I'm just conscious of the time. We'll go back to dementia, back to brain aging. So what we were getting at when I took that aside, and thank you for coming on the methodological journey with me. I do love brain imaging methods. It's one of my favorite things, but we're talking about them because vascular changes are a leading cause of dementia. And we can use this kind of catch-all term, vascular cognitive impairment, when we're talking about changes to our thinking and memory associated with vascular changes. So we've got, just to define our word here, our term, and sometimes I'll say VCI, vascular, is anything related to the heart, blood flow, or blood vessels. And then of course, cognitive, cognition, thinking and memory, the thing that's impacted in dementia. And then of course, impairment, worse functioning. So it's important to get the word out that these vascular changes are a leading cause of dementia because we can do something about them, right? We know there's really well established research to show how to improve your vascular health, and we can use that to protect our brain too. So one of the projects that I'm involved in is creating a video series about how we can do a better, what vascular cognitive impairment is, so that we get the word out about it, so that we can make good, healthy choices in our own lives and also try to influence our community to take advantage of this opportunity we have to reduce dementia by improving our vascular health. So the video series isn't quite ready yet. There's a 4-part video series. They're each about 10 minutes long, but I do have a 3-minute trailer to show you, to give you an idea of what we made. And this was made in partnership with not just universities, but also this organization called EPLED, or the Engagement of People with Lived Experience of Dementia. So these are patients and their family members that shared their own experiences and their priorities for what they wanted to see in our video series. So that was a really, really interesting experience to make this series with them. So I think it'll just play. All right. Let me get the sound up a bit here. Probably over here. Okay, that's weird. Did it just change color? Oh. Let's try it. And Derek, do you remember how we got this a little louder? Is it on down here? See? All the way maybe here. Let's try. Yeah, sorry. Thank you. We did test it. There, thank you. That's great.
NSIS is an umbrella term that refers to the whole group of diseases that blood vessels or the heart that can affect the brain. It's not a single disease. It's a condition caused by alterations in blood flow to the brain. This injures the brain and prevents the brain from being able to think or process information. Started in 2008. I had memory issues, confusion, losing things. My family doctor was going on for 30 years. I told him I think I have dementia because I was that. And he said, "You don't have dementia. You don't have to argue that."
I didn't really notice changes in my husband. It was my children who began to notice changes in him. And they kept saying to me, "Something's the matter with Dad. He's not remembering things. He's saying things that he normally would not say."
I think getting a DCI diagnosis can be helpful because they are the risk factors that we can look into and modify, and that provides the hope that we can stabilize the disease and prevent it to slow down in the future of things.
Right from the get-go, when I was told I had dementia, I said, "Okay, that's very important because once we accept it, then we can deal with it."
I had a visit for their question to I would invite you to be mindful of this view and your technique.
Your journey with DCI is going to be outdated. So they're also going to be doing others that are impacting you. And without for everybody to all that doing, I don't feel so we have to important to read because now it's mostly
So don't put on yourself. Don't put on the people around you because it's very interesting too. So let's find a way to all have faith. And let's find a way to help each other so that you can thrive. You can thrive.
Any kind of, I hope you could hear it okay, reflections on that? Did parts resonate? That's okay. So I do want to get to what can we do? So there's some things that we can't control that impacts our risk of dementia. So just the higher that number is, that is your age, the greater risk of dementia you have. Being assigned female at birth increases your risk of dementia. And your genetics, there's many, many genes that have been associated with dementia risk. But there are some things that can be controlled. And I'm going to be careful to say this because our degree to control these things depends on our situation, our privilege, what our community can offer us. But some of the things that we might be able to control include diet and exercise, and heart health we have down at the bottom, but also social activities and intellectual activities. So maintaining your social connections and maintaining your intellectual hobbies can help reduce your risk of dementia. And protecting your brain from injuries is another big one. So if you have had a brain injury, you're at a greater risk of developing dementia. Blood pressure medication is the only known effective preventative medication for dementia. So the only pill that you can take that might prevent your dementia or reduce your dementia risk is blood pressure medication, antihypertensives. So now obviously don't take those if you don't have high blood pressure, but if you do have high blood pressure, it's really important to get that blood pressure under control to reduce your risk of dementia. And so it's this kind of action, this kind of potential action, why I think it is so important to get the word out about vascular cognitive impairment. Because I worry that people might be out in the community, they might be noticing, my memory, I'm having problems with my memory, my thinking isn't as fast. But if they skip right to, oh, it's Alzheimer's, there's probably nothing I can do, they might not go to the doctor and deal with their vascular risk factors, which can slow or prevent or maybe even reverse some dementia symptoms. So it is so, so important to go to the doctor if you feel like you're experiencing changes to your thinking and memory that is impacting your daily life. Or if someone who knows you really well thinks that, right? Someone in your circle is noticing changes to your thinking and memory. This is a kind of a busy diagram as well, but these are some factors again that can reduce our risk of dementia, either prevent or delay its onset. And so again, some of these are things that we have some control over and some more than others. So, one that always sticks out to me is reducing air pollution. Well, you could go and live in the woods and reduce your exposure to air pollution, or we could come together as a community and try to have cleaner air, right? So we don't always have individual control, but it doesn't mean that we can't do something about it. And then I think some important ones are down here as well. Not that some of these aren't important, but continuing your intellectual activities, important way to reduce dementia risk. One that might be less well known, but I think makes sense when we think about it, is preventing or addressing hearing loss. So, making sure that you get a hearing aid or that your loved one gets a hearing aid if you notice hearing issues, because by addressing the hearing loss, you can reduce dementia risk. And I think that we don't know exactly the mechanism of it, but even if you think about the social and intellectual factors that are important for reducing dementia loss and the impact of dementia risk, I should say, and the impact of hearing loss on those types of activities, it's fairly, becomes a little bit intuitive. And then helping increase social contact. And so this is another very community facing issue, right? So how can we reduce loneliness in our community? How can we make sure that people have opportunities to maintain their social connections? This isn't something you can do on your own. It's right in the name, social activities. And so there's different mechanisms. It says proposed mechanisms up here. Forget how to hide this. There it goes. I didn't do anything there. So different mechanisms that many of these different risk factors might act on multiple mechanisms, but including vascular damage, which we talked a little bit about today. But lots of overlap going on. And then just to circle back to this idea that not everyone can control their level of risk on every factor, the Alzheimer's Society of Canada said it nicely. Modifiable risk factors might not always be modifiable for individuals. So one example that I like to share is that individuals who are experiencing homelessness or housing instability are at a greater risk of sustaining a brain injury than the general population. And then we know that brain injury confers this risk of dementia. And so we can think about the social determinants of health, or kind of more broadly, or we can think more specifically about the social determinants of dementia. What structures in our social system can we take advantage of, can we strengthen to reduce our dementia risk as a community? And reducing homelessness and increasing access to affordable housing, I think, is an important one. So we'll kind of start to wrap it up here, but messages that I would love for everybody to take away from this evening are to keep your heart healthy, to reduce your dementia risk, and to go and see a healthcare provider if you're experiencing thinking and memory problems, because your vascular risk factors are something they can help you address, which could slow or even prevent progression. And also just invite you all to work with me to advocate for equity in order to reduce dementia risk for our community as a whole. So how can we improve access to safe and affordable housing, healthcare access, and other structural structures, other social structures that could help improve brain health for everybody. So thank you so much for coming this evening. I want to also invite, if people do want to keep in touch, for example, if you want to see the videos when they're released or learn about research that's going on in the lab, if you scan the QR code, you can give me your email address and I'd be happy to keep in touch and continue the conversation. I also, if you want to come look at some brain models, I have some brain models up here and happy to take questions as well. Thanks, everybody. Yeah.
Like, I think it was it 183 or one?
Yeah.
Yeah, what's this? Is we're living longer, but is that the one of those numbers?
Yeah, so where do we get the numbers that we're gonna increase dementia prevalence by 190% in the next 25 years, and longer life expectancy does have a lot to do with it for sure. So as we live longer as a community, we get greater dementia risk. And so those numbers come from a study that did some modeling based on the rates of dementia risk factors in our population now and how they've been increasing. So it's not just age, but a lot of the other things that I had on that slide with all the arrows that they are projecting will increase based on how they've been increasing in the past. So it's very multi-dimensional. Yeah, thank you. Yeah. Yeah, hi.
I'm interested in the connection between gender and dementia. It's connected to heart health, mental health. Women are more about health risks.
Yes.
Heart risks. So is that the connection? We know why.
So you might guess that it is a criminally understudied area of research, right? Who would think that? But some of the things that we know about brain health for women specifically is that estrogen is neuroprotective, but that we have been discouraged from things like hormone replacement therapy for decades. I'm not advocating for hormone replacement therapy. I'm not a medical professional to do that, but estrogen does have neuroprotective features. We also have longer lifespan, like this could be a lifespan, a life expectancy feature. But it is a struggle. It's very frustrating that I don't have a better answer for you. And I would love to also personally do more research in that area. Yeah, thank you for asking.
And just one thing, you talk about how we would say people housing, I would also have made something like basic income guarantee is a structural.
Yes.
That would allow social equity.
Absolutely. Guaranteed minimum income could improve brain health in addition to solving a lot of problems and be a lot cheaper in the long run. Totally agree. Thanks for bringing that up.
It's wonderful you brought this in.
Thank you. Thank you for having me. Thank you for coming. Doesn't work if nobody comes. Any other questions? Yeah, Joe?
Curious about the cause, can you explain the connection power? Brain damage?
With cholesterol? Yeah. So the question is, what is the link between high cholesterol and brain damage? That's definitely not something that I'm an expert in, but I believe it's quite bad for your blood vessels to have high cholesterol, which means that it's harder for your blood vessels to respond to increased demands. So we want our blood vessels to be nice and elastic so that when we have a need for increased blood flow, they're able to balloon out to meet those demands. So I believe that's the mechanism, but yeah, sorry, I'm not more confident on that one. Yeah, Tate.
How serious of a brain injury does it need to increase your risk, like a simple concussion do it, or falling off your bike and setting 12 miles an hour, is that gonna be a bigger risk, obviously?
Yeah, so how serious does the brain injury need to be to increase your risk of dementia? My understanding is that a concussion does increase your risk of dementia by a little bit, but repeated concussions increases your risk by something like 2 to 4 times. So it doesn't necessarily have to be, extremely serious in terms of like an open head injury or something, but repeated concussions can increase your risk pretty substantially. Yeah. Yeah, so why do more females experience dementia? I know several bright ladies who have developed it. Why? Yeah, so there's so many different factors. So we talked about the protective effect of estrogen, and as we have decreased estrogen as we age, we might be kind of having both age-related changes and estrogen reduction changes negatively impacting the brain. But I don't have and we also know that the women have a higher, longer life expectancy than men, and so we get kind of greater opportunities to develop dementia, but it's a very understudied area. I'd love to have a better answer for you. Why is there projected increased risk for dementia in the future? That was another question that was in the room, so I didn't repeat it, but this is related. So the projection comes from modeling where we've looked at, and not me, but the Alzheimer's Society of Canada has looked at how risk factors for dementia have been changing over the last couple of decades and how they're projected to change and how that's going to impact dementia prevalence in the next 25 years. So it has to do both with increasing life expectancy, but also those other risk factors that I shared. Anything else?
I have a question.
Okay.
Okay, so previously you talked about or shown how intellectual abilities has a very important component regarding brain health. So is it true then learning a second language is something that actually can help improve brain function? And if true, what exactly is about learning a second language that has conveyed or conferred, sorry, this protective effect?
Yeah, great question. So when we think about how intellectual activities like learning a second language are protective against dementia risk, we often invoke this concept called cognitive reserve. So cognitive reserve is this idea that everybody has a different ability to respond to pathology, like brain changes that might result in dementia or other insults to the brain too, like a stroke, for example. And so when people have higher cognitive reserve, they experience less of the negative effects of a dementia diagnosis or a stroke. And so we think that intellectual activities like learning a second language lay down a lot of new connections, which means that when other connections fail, we've got like a secondary route for the processing to take place. But that's really just a theory. Yeah. But thanks, Sid. Yeah.
So we can always renew or not renew, but grow.
Yeah. So can we always grow new connections? So yeah, the idea that your brain is plastic and we can grow new connections. Anytime that you learn something new, that's happening in your brain. And you're either growing new connections or strengthening existing connections. And yeah, that's a lifelong thing. It's easier when you're a kid, as my kids in French immersion are proving to me as they learn a second language like that. But you could, if you're learning something new, it's because there's changes going on in your brain. Absolutely.
Talking about language, dementia seems to have some stigma with it.
Yeah.
And so should we be saying fast or other than touching? What do people from the community want? What is it for language and just more, I don't know, person-centered, or what's the right way to say?
Yeah, great question. So the question is about language regarding dementia and acknowledging that dementia is stigmatized. And I think I just want to add to your question that the more that we can reduce that stigma, the more people might go to the doctor when they're experiencing symptoms. So it's super, super important to think about how we can destigmatize dementia. So we tend to use like person first language when we can. So it's a person living with dementia, not a dementia patient, would be the alternative. And we want to emphasize that this is just one thing. You can be a person, living with pets, and you can be a person living with dementia. But we also don't want to minimize the challenges that it brings to, so it can be really tricky. So my advice would always be, and I feel like you've probably given people similar advice on different topics, would be to just ask the person that you're in front of. But I usually default to just a person first language. Another really important language bit that's shifted quite recently is the idea of a care partner. So that's this language that we use really intentionally, and it's shifted from caregiver, and it is intended to reflect that this is not a one-directional relationship, and that care partners are just one part of that dyad, and that the person with the dementia diagnosis is also contributing to the relationship. So that's another one that we use, but thanks for asking. Emma?
I was wondering, if you think about the stress they have, is really stressful, like, but then could that be sort of a precipitating factor for symptoms?
Yeah, absolutely. And so if we think about things like adverse childhood experiences, for example, ACEs, where people might experience something quite traumatic in childhood, for example, they are definitely at risk of worse health in general and brain health specifically. I don't have the numbers for dementia top of mind, but one of the things that isn't totally intuitive is that people with adverse childhood experience history have a much higher risk of stroke. So it's that vascular piece, could be like inflammation increasing related to stress responses, negatively impacting vasculature. But good question. Very hard to do those kinds of studies well. So we're just kind of looking at it now. Yeah, thank you. So the question is, oh yeah, so that's a good question. So is the switch from caregiver to care partner, going back to the language question, is that specific to the dementia community? This is sort of like my bias because I'm not as involved in other communities to know. It is specific. It isn't. Okay, I was going to say, I don't see why it would be. Thank you, Ruth, for having my back there. So no, I think care partner, to me, and it's intuitive that it has that appeal more broadly. Oh yeah, so I've read that dementia starts years before symptoms even start to show. Is there a point at which lifestyle changes will make the biggest impact? Great question. So the point at which lifestyle changes will make the biggest impact is today, because we can't go backwards. So start immediately to make those lifestyle changes and community changes, and write your MLA about guaranteed minimum income and make those changes as soon as you can. But I will say too, if you had very good vascular health in young adulthood, for example, and then you stop, your risk is not that much lower than than someone who wasn't active in their youth. So maintaining all of these healthy choices is super, super important, or just starting them now. I have not spoken at the Brain Injury Association of Nova Scotia. I do know what that acronym is. Sorry, Derek. And I also, sorry, go ahead.
Really brain health, cognitive clarity. Research on that, or
No.
say about that, or vitamin D, like is there something that talk about the lifestyle and community things that we need to do?
What about vitamins? So that's a great question. So like I mentioned before, it's only those antihypertensive, only that blood pressure medication has been demonstrated to make an effect. So that's not to say that there isn't a positive effect of those vitamins. There is some evidence that vitamin D might be protective against multiple sclerosis, just at the normal dose of vitamin D, not the hyperdosing that people do. But we don't have the studies where we would make a statement on that. So something that I would always recommend is if you feel like it's helping you and you are using it like within safe dosages, probably isn't going to hurt, but obviously talk to your healthcare provider too. Yeah, but no clear research on those ones. Yeah.
All right, so it looks like we're coming near to an end. I do have one last question if no one else does. Okay, you've already touched on it before, but I might as well ask directly. What is the biggest misconception that Hollywood has about brain health?
Oh, biggest misconception. Well, I don't know. Can I share a different story instead?
By all means.
Okay. So I was super excited, and this is not a recommendation to watch this show. It's not for everyone, but I saw for the first time ever on a TV show, they mentioned vascular cognitive impairment. They mentioned, and it's a Netflix show. It's called Fall of the House of Usher. It's extremely gory. But if you want to see vascular cognitive impairment on TV, that's the only place you'll find it. So, and it's as more or less accurate. Yeah, thanks.
All right, and I guess one last comment, just because obviously the brain bee is very important to you. And so I've got something written here, so please bear with me. All right, so as one of the 3 finalists named as a 2022 emerging professional, as recognized by the Discovery Center, who is one of the supporting partners for the NSIS, you said in an interview, and I'm going to paraphrase, I've never really pictured myself as a scientist, and that's one of my motivations for doing science outreach, specifically with girls. Funding for getting girls and women involved in science is really important to bringing diverse perspectives and solving problems in novel ways that we haven't considered before. So this is 2-part question. One, why didn't you picture yourself as a scientist, and what made you realize that you wanted to become one or now were one?
Yeah. Oh gosh, I'm a scientist. So when I was in junior high, I did possibly the worst science fair experiment you have ever seen. I won't bore you with the details, but I did a really, really terrible job at a science fair, and it really turned me off. And so at Brainbee, actually, we do something called the reverse science fair, where we do our science for the high school students and they get to vote on the best one. So I'm, working out something through that. So that was, I think it was science fairs really turned me off. For other kids, it's a positive thing, but for me, I don't know, it was the competitiveness or really didn't work for me. Yeah, and then I went to university here. I went to my undergrad at Dalhousie University down the road. I'm from Dartmouth originally. I meant to share that earlier. And I really, really enjoyed the Dalhousie Integrated Science program there. So shout out to them. And I did that program, and I've been sense.
Okay, and part two, particularly as we do have some younger individuals within the in-person and presumably online. What would you say to all the budding young scientists and people interested in science that you wish someone had said to you?
I think what got lost for me was you get to pick the question. Like I can go find out whatever I want about the world. What the curiosity part. So if you find yourself curious about things, science allows you to come up with an answer. Yeah, that's what I'd say.
All right, thank you so much. All right, so I think that we are going to wrap up, given we've kind of got a little beyond the prescribed time. But again, I would like everyone to take a moment to, again, thank you, Dr. Erin Mazerolle, for sharing this fascinating topic.